Hello and welcome to the 2018 ABR Non-Interpretive Skills Study Guide Review Series. This is David Larson at Stanford University, and thank you for joining me again today. We're continuing where we left off in the study guide. So next we're going to be talking about core concepts of safety. So the first question is, according to the 2000 IOM report to Erris Human, how many annual in-hospital deaths are attributable to medical error? All right, so the 2000 IOM report to Erris Human was kind of an earthquake that hit the public when a number of high-profile reports became widely disseminated and really kind of shocked a lot of people, and in many ways kind of started the patient safety movement, at least in the modern times. So the number that was reported was approximately 44,000 to 98,000, and that has been validated in subsequent studies. In fact, if anything, it probably was actually a relatively low estimate. Again, this report made national headlines. It was highlighted as an epidemic of death from medical errors. As you can imagine, the public was quite upset about it. Resulted in many congressional hearings and a lot of effort into what we do next to reduce this harm. This number of deaths exceeds the number of deaths from motor vehicle accidents, breast cancer, AIDS, total society costs of $17 billion to $29 billion. So kind of a big deal. So according to the 2000 IOM report to Erris Human, what is the definition of medical error? According to the report, medical error is defined as a failure of a planned action to be completed as intended or use of a wrong plan to achieve an aim. So just kind of a fundamental definition of error in general. Either you meant to do something and it didn't work out as you wanted to do it, or you really didn't know what you were doing in the first place. You chose the wrong plan. Next question. According to the 2000 IOM report to Erris Human, what is the setting for the highest risk of medical error? So not surprisingly, perhaps, the highest risk environments are those that are high acuity environments, the ICU, the OR, the emergency department, and so forth. So if you can imagine areas where there's a lot going on, where patients are at high risk in terms of their health status, where it wouldn't take much, a minor problem can turn into kind of a disaster. Next question. According to the 2000 IOM report to Erris Human, what are 4 fundamental factors of the health system that contribute to medical error? All right, so those 4 factors that were cited are the decentralized nature of the health system, or it actually said non-system, failure of licensing systems to focus on error, impediments of the liability system to identify errors. In other words, the tort system or legal system basically encourages practitioners to hide their errors rather than to highlight them. And finally, failure of third-party providers to provide financial incentives to improve safety. In other words, insurers are paying for care in terms of volume of care. Generally, they're not paying for quality of care, and certainly not safety, at least not historically. Next question. According to the 2000 IOM report to Erris Human, what is the cause of most medical errors? According to the report, most errors actually have multifactorial causes. It's not just one cause, so it's a bit of a misnomer to think that there's a single cause. Usually they're attributable to both unsafe systems and processes of care as well as human error. So, therefore, then the strategy that's most likely to be successful in the long run is to design safety into the systems and processes of care, not simply blaming individuals and rooting out the bad apples. That's a historical approach and shown to not be effective. It's also pretty miserable to work in, so we got to focus on designing safety. Next question. According to the 2015 IOM report, Improving Diagnosis in Healthcare, what is the definition of diagnostic error? So the 2015 IOM report really focused on diagnosis. So it has special relevance to radiology. Obviously, it came out much later than the earlier reports, and it was considered to be the third in the series from the error report to the quality chasm report, which kind of outlined an overall vision, and now we're focusing specifically on error. So diagnostic error is considered to be the failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. The definition is purposely patient-focused. So patients are considered to be key team members in efforts to prevent diagnostic errors. So we should utilize and work with the patients to make sure that these errors, or at least decrease the likelihood of these errors happening. Diagnostic error in general is considered to be an underappreciated problem. The data on diagnostic error are relatively sparse. There are few reliable measures. Errors are identified generally only in retrospect. So diagnostic error is a challenging problem, but one that's increasingly more recognized, and increasingly, especially in specialties such as diagnostic radiology. In many ways, it's a team sport because we do the diagnosis, but we've got to make sure it's communicated and incorporated into the patient's care. Next question. According to the 2015 IOM report, Improving Diagnosis in Healthcare, how often do diagnostic errors occur? Well, the report said that nearly all Americans will likely experience a meaningful diagnostic error in their lifetimes. Approximately 1 in 6 Americans surveyed had experience with a diagnostic error, either personally or through a close friend or a relative, and 10% of postmortem examinations associated with a diagnostic error were associated with diagnostic errors that might have affected patient outcomes. So basically the point of this is it happens a lot more than we would like to think, and so it's the problem that we need to really address. Next question. According to the 2015 IOM report, Improving Diagnosis in Healthcare, what should be the approach to reducing diagnostic error? So in many ways, it's not exactly what you might think. Of course, we need to continue to improve our clinical care, our clinical acumen, but it's also other aspects like, first of all, making diagnostic error a focus of quality improvement efforts by the healthcare organizations, making sure those efforts are objective and non-punitive. Again, as we discussed before, improving systems and processes, learning from both errors and near misses, also learning from exemplary, accurate, and timely diagnoses. So learning from the good examples and taking that back and applying it to where it didn't work so well. And in general, recognizing the value of collaboration between professionals, and that healthcare is increasingly a team sport and a collaborative sport. The major theme of this report is teamwork and collaboration. Next question. Name at least 5 of the 8 recommendations for improvement in the diagnostic process in the 2015 IOM report, Improving Diagnosis in Healthcare. Okay, so again, a lot of this is focused on teamwork, as we discussed earlier. So the 8 are that we should facilitate more effective teamwork among healthcare professionals, patients, and families. And radiologists and pathologists are an integral part of the diagnostic team, and we need to act like an integral part with our referring colleagues. To enhance healthcare professional education and training in the diagnostic process, ensure that health information technologies support patients and healthcare professionals, especially as it comes to communication. Develop and deploy organizational approaches to identify, learn from, and reduce diagnostic errors and near misses. In other words, we all get together and be systematic in how we're going to reduce these errors. Establish a work system and a culture that supports the diagnostic process and performance improvement. So this may include redesigning the payment structures, especially as regards to fee-for-service payment that really lacks incentives to coordinate care and improve communication around test ordering, interpretation, and decision-making. So we're likely to see increasing payment models that really support collaboration and performance improvement. Number 6, develop a reporting environment and medical liability system that facilitates improvement. Number 7, design a payment and care delivery environment that supports diagnostic process. Specifically, oversight bodies should require that healthcare organizations have programs in place to monitor the diagnostic process and identify, learn from, and reduce diagnostic errors and near misses in a timely fashion. And finally, provide dedicated funding for research on the diagnostic process and diagnostic errors. So these are, as you can see, very high level elements, and so these are things that we should know about, that this is kind of where the field is going in terms of some of these high level aspects to prevent error. Next question. According to the 2015 IOM report, Improving Diagnosis in Healthcare, what specific factor contributes to diagnostic error in radiology? And we hit on this before. That is mainly communication. So 4 things that both IT and clinical leaders can do to improve communication that have been identified. First of all, have standardized communication policies in place, and as well as definitions across networked organizations. So in other words, we all define how we're supposed to communicate and what our communications mean. Number 2, ensure clear identification of the patient's care team to facilitate contact by the radiology team. Anyone who's spent any time in radiology knows how challenging this tends to be. Number 3, implement effective results management and tracking processes. And number 4, develop shared quality and reporting metrics. So again, this is likely going to be continued focus for our field. Next question. What is the focus of human factors engineering as a discipline? What is human factors? So human factors focuses on the interaction between workers, equipment, and the environment. So it focuses on enhancing performance, especially human performance, minimizing the strain on the individual, and minimizing the risk of error. So it really comes out of kind of industrial engineering in terms of how humans work with equipment and the environment. Next question. Provide 3 examples of events in which human factors plays a role. Okay, so this comes from the study guide. First example, an OB nurse connects a bag of pain medication intended for an epidural catheter to the mother's IV line, resulting in a fatal cardiac arrest. So the problem here was that the bag of epidural anesthetic was similar in size and shape to the IV medication bags, and crucially to the same catheter, that the same catheter could access both types of bags. So the point here is you can just pin this on the OB nurse, but the reality is it was kind of a disaster waiting to happen, and if you just blame the OB nurse, this is likely going to happen again. So a human factors engineer would look at this and say, you need to engineer this in a better way so that it makes it harder to do the wrong thing and easier to do the right thing. Another example, a newborn in a neonatal intensive care unit is given a full dose of heparin instead of a low dose heparin flush, leading to death from intracranial bleeding. Here, the full dose and prophylactic dose heparin vials appeared virtually identical. Both concentrations were routinely stocked in automated dispensers at the point of care, so you can very easily imagine how this could happen. So changing some of those elements would be something that you would do as a human factors engineer. Third, an elderly man experiences cardiac arrest while hospitalized, but when the code blue team arrives, the team is unable to administer potentially life-saving shock treatment because the defibrillator pads cannot be connected to the defibrillator itself. So this is where we have problems with systems working well with each other. So, for example, multiple brands of defibrillators exist that differ in physical appearance as well as functionality, and a typical hospital may have many different models scattered around the building, sometimes even on the same unit. So this requires kind of a systems level approach where you're not just looking at that specific defibrillator device, but you have to look at the whole thing in context. Next question. What general approach to human factors engineers do human factors engineers take to improving processes? Well, generally they take into account human strengths and limitations in the design of interactive systems that involve people, equipment, technology, and work environments to ensure safety, effectiveness, and ease of use. In other words, they don't just assume humans are going to act perfectly every time, and humans actually have kind of predictable types of errors that we commit, and so we need to design around that. Human factor engineers examine a particular activity in terms of its component task, and then assesses the human physical, mental, and skill demands in the context of team dynamics, work and work environment, like adequate lighting, limited noise, or other distractions. So it kind of takes everything into account, and then designs a device or the work environment or systems in a way to optimally perform the task, optimize safety, and minimize risk of error in the complex environment. So really the focus is on how systems work in actual practice with real and fallible human beings at the controls, not just how it would work in the perfect situation. Next question. In what other fields has human factors engineering been applied? Well, the reality is it's been applied in many fields, kind of applied across the board. But so those that have been really highlighted include other high-risk fields like aviation and nuclear power. Application to healthcare has been relatively recent. It's now much more widely applied. An example of human factors engineering in healthcare is redesign of anesthesia equipment to make sure that it works well with the anesthesiologist and really sets them up for success, and has resulted in major safety improvements over the past few decades in anesthesia. Next question, why should equipment and processes be standardized? Kind of a general question. Well, mainly to increase reliability, to improve information flow, and to minimize cross-training needs. There are a number of reasons why you want to try to standardize to the extent possible. In general, standardization frees team members to focus on unique aspects of the case. So if there are certain elements that are always the same, no matter who does it or what environment you do it in or when you do it, then you can now focus your cognitive effort on really the most important parts of it. So in general, when you go to standardize a process, I mean, it's basic. It's a pretty basic approach to standardizing. First of all, you got to agree on what are the elements of the process that should be standardized, what should be the standard elements. Then once you have an agreement on it, you incorporate aids like checklists and other ways to make it easy to do the right thing, and then hard to do the wrong thing. And then you monitor your agreed upon performance and make sure that you're actually doing what you're supposed to be doing. And you have lots of people who are aware of what the standard is supposed to be. Lots of handoffs, and so this allows a lot of extra eyes to see when things are going wrong. So the concept is, if instead of everybody does it their own way, if everybody's supposed to do it the same way, if something is out of whack, it's really easy to see when it's out of whack, rather than it's just, well, that's the way that they do it, and it's a lot harder in that case to see when something's going wrong. Next question, what is the definition of communication? The definition of communication is the meaningful exchange of information between individuals or groups of individuals. It's important to recognize that it's often bidirectional or multidirectional, and successful communication happens when it results in shared understanding of meaning. So the main point here is, if it doesn't result in a shared understanding of meaning, it doesn't count as communication. So you can't just throw it over the fence and just assume that it happened. That's not effective communication. Communication results in new understanding of something. Next question, communication consists of what two major parts? The two major parts of communication are conveyance and convergence. So conveyance means the transmission of information from sender to receiver, and then convergence is that verification or discussion or clarification until both parties recognize that they mutually agree or fail to agree on the meaning of the information. And most commonly, where the failures occur, it's in that convergence. So yes, you can throw it over the fence, you can transmit the information, but you have to make sure that it actually got to the individual and that they understand the meaning in the same way that you understand the meaning. Even if you disagree, at least you have a common understanding of what you're trying to communicate. Next question, when are convergence activities most critical in communication? This is mainly when information is ambiguous and when the negative impact of a miscommunication would be severe. So in other words, if you're reading a study and it's kind of difficult to put in a report, just get on the phone and call them and have that discussion and clarify what you're talking about. If it's straightforward, it's not a big deal, but if it's not very clear, that's obviously when you should get on the phone. And also, even if it is straightforward, but if somebody happens to not look at it or they happen to misunderstand it, if that would result in something catastrophic, they've got to act on it right away and they have to understand it, then that's another situation where you just got to get on the phone and have that close that loop to make sure that everyone understands what you're talking about. Next question, what is the definition of a high reliability organization, or an HRO? A high reliability organization is one that, despite operating in a high stress or high risk and complex environment, continually manages its environment mindfully, adopting a constant state of vigilance that results in the fewest numbers of errors. In other words, they work in just an environment that could result in disaster at any time, and so they're able to navigate that difficult and complex environment effectively, despite that it's high risk. And so this serves as a model for healthcare. So some organizations who have figured out how to do this, they have certain practices that they use, and so that's what we aspire to in our environment. So the first element of that, describe preoccupation with failure in the setting of a high reliability organization. The concept of preoccupation with failure is based on the concept that people recognize that even minor lapses can have severe consequences. So even if you see something minor, you don't just accept that because you recognize that that could end up being a disaster. They deliberately watch for clues that indicate trouble, and organizations have processes in place to enable individuals, teams, and systems to quickly detect and respond to potential threats before they result in harm. So they're constantly kind of paranoid and worried about failure. They don't tend to dismiss it. They don't overreact either necessarily, but they have processes to quickly look at it when there are clues and decide whether or not they need to do something more. If they do, they can do it very quickly. Next question, describe reluctance to simplify in the setting of a high reliability organization. So reluctance to simplify just refers to the concept that people do not accept simple explanations for causes of problems, but instead they dig deeper. In other words, you don't just hear the first explanation that somebody came up with and say, oh, okay, that must be it. And instead, you really go and find out what's actually happening, make sure that there's not something more serious afoot. Kind of related to that first one. Next question, describe sensitivity to operations in the setting of a high reliability organization. So this concept is really dealing with how people, especially leaders, understand the messy reality of the details of what's actually happening in the workplace rather than what's supposed to be happening. And they recognize that the thing that's supposed to be happening often is not the thing that's actually happening, so they don't trust it. So they then respond with the assumption that there's probably a difference unless you can actually see it with your own eyes. This is especially related to summarized data and reports. So you don't just look at the data and assume that everything's okay. You go out and you verify, see what's actually happening, understand the clues, get information from multiple sources, recognize that people on the front line probably know some things more than the leaders know, and you better incorporate their perspective or else you're going to get yourself in trouble. Next question, describe commitment to resilience in the setting of a high reliability organization. So this concept focuses on the assumption that unexpected trouble is ubiquitous and unpredictable, and you recognize that the organization can never fully anticipate each unexpected event. And so you know you're going to do your best to prevent it, but it's just you're not going to get every event, and these things are going to slip through. So you need to empower individuals to adjust and innovate as necessary to deal with these problems and sometimes these disasters as they unfold. And then you seek to learn from those situations after the fact. So one example is if an emergency occurs, you let your people use their common sense, and even if it means violating protocols, and people need to know that they just need to do the right thing for the patient in the setting, but then they need to understand afterwards there's going to be a discussion about what they did and why they did it, and it's not that you can just violate protocols as you wish, but if you think it's best for the patient, then you can just go ahead and do what you think is best, and then we can discuss it, and we may need to change the protocols or policies. Next question, describe deference to expertise in the setting of a high reliability organization. So deference to expertise refers to expertise not necessarily of who is the smartest person in the room or who has the most degrees, but it's more who understands the details about what's going on in a given situation. And so there's the assumption that no one individual can know everything about every situation. And in fact, people with greater authority often have less useful practical knowledge. They may have more knowledge in general, but they may not understand the details of the specific situation. So HROs overcome the dangers of hierarchy by enabling leaders to defer to the relevant expertise regardless of its source while preserving the organizational structure, while preserving that respect for the leader. In other words, if you've got someone who's running a code situation, for example, and a nurse and a technologist, they have some information that they understand that the person running the code may not understand. There should be this ability to freely speak up and sometimes even challenge what's going on. But at the same time, then the person who receives that needs to have a way to acknowledge that and incorporate it. But if they understand it and they still want to move forward, they have to be able to move forward. But it can't be viewed as challenging someone's authority. It has to be viewed as just a natural part of how we work. So again, that example, that nurse who's worried about maybe seeing something the doctor is not seeing and should be listened to. This may be a technologist, but you need to be able to accept that and recognize their expertise in that given situation. Okay, we're going to go ahead and stop there. Thank you again for watching. This is David Larson reviewing the 2018 ABR Non-Interpretive Skills Study Guide.